Okay, so this is chapter 24, talking about diabetes mellitus. You are looking at a stained slide of the pancreas, and we have the exocrine cells in blue, the nuclei stained blue, the islets of Langerhans, or the pancreatic islets, in different colors, and the red color is going to stain insulin. So we can see all the cells that create insulin, the beta cells, all the cells with glucagon. So just a little history of diabetes. Diabetes has been with humans or the record has been as far back as when records were first started to be kept with the ancient Egyptians. And so they called it a disease characterized by a great emptying of urine. And Indian physicians actually called it, I'm not going to try to pronounce that name, but honey urine. It attracted ants. And then the Greeks coined the term diabetes to mean siphon, because they saw that people with diabetes urinated a lot, so things sort of siphoned through the person. Copious amounts of fluid went through them. Mellitus is sweet like honey. And how do you know the urine is sweet? Because they had to taste it. So this British Surgeon General could distinguish diabetes from other diabetes, the diabetes insipidus, where the urine was tasteless, but mellitus was sweet, right? So they had to actually taste the urine to figure out what kind of diabetes you had. So diabetes has many effects throughout the whole body. It can affect the brain, the eyes, the heart, the kidneys, the gastrointestinal tract, the gonads and blood vessels. So impotency, because the vasculature, and really that's what causes a lot of the symptoms throughout the whole body, is that it attacks the microcirculation of the body, the small arterioles, the capillaries, and the small venules. And so impotency, of course, is with that blood flow. The peripheral nerves, the foot ulcers in the feet. So it's a body-wide disorder that affects all different kinds of tissues. So there are two kinds of diabetes, type 1 diabetes and type 2. So starting with type 1 diabetes is an autoimmune disease. So this kind of diabetes is going to be your own immune system attacking your body cells. And specifically, it's going to be the beta cells of the pancreas that are being destroyed specifically. And the cause of this autoimmunity is really not known, but they think it has to do with sort of a two-pronged approach to both having some kind of genetic component to it, as well as a viral infection. So environmentally, they looked at people who have been, the rates of diabetes type 1. You can see Coxsackie virus infections, and you can see Epstein-Barr infections. And those viruses cause the immune system to kind of also attack the beta cells of the pancreas. So it's a really interesting sort of combination there. It's not, if you look at the numbers here, the most prevalent form of diabetes is actually type 2 diabetes, where 90 to 95% of people in the United States have that. What they call type 1 diabetes, because it is an autoimmune disorder of the pancreatic cells, this tends to present itself when a person is very young. So the average age of onset is about 7 years old, and into early adulthood. And so they call this sort of juvenile onset diabetes mellitus, or they call it insulin dependent diabetes mellitus, because it depends on your ability to make insulin or not. And of course, if you're destroying your beta cells, you're not making insulin. So if you look at the familial, so it turns out that if you look at the genetic component of both types of diabetes, that type 1 diabetes, they both have a genetic component, but the more strongly associated genetic component is actually within type 2. So type 1 diabetes, in the textbook, it says that there's twins. If you have identical twins, the twin only has 30 to 50% chance of getting diabetes. If one twin has it, then the other twin is only 30 to 50% chance. Whereas in type 2 diabetes, it's 60 to 80%. So it's much more of a stronger genetic component in type 2 diabetes. So for type 1 diabetes, it really is due to this impaired ability to make insulin yourself because those beta cells are destroyed. So you would look for a decreased blood insulin. Because you are not making that insulin, you'll have elevated blood glucose. And then there's other things here, right? And then this should make sense too, the presence of antibodies to those beta cell components, right? You're not going to have that in type 2 diabetes. So let's take a look at the type 2 diabetes. Type 2 diabetes is the kind that is the most prevalent form, of course, and it's called insulin independent or adult onset or non-insulin dependent. So for people with type 2 diabetes, they do have insulin. Their beta cells are fine. They're making insulin, but the tissues are not responding to the insulin. So the pathology is that the tissue is resistant to insulin. So it's a little bit more complicated than, type 1, because type 1, if you don't make insulin, then you can treat that person with insulin. But type 2 diabetes, it's more complicated. You do make insulin. You're just not responding to it. So this form of diabetes is linked with genetics, but also with lifestyle. So you could find that people with type 2 diabetes tend to are overweight. They tend to have a sedentary lifestyle, and they tend to have a diet that is high in sugars and high in fats. And so this kind of diabetes tends to come on in adulthood, which is why it's called adult onset diabetes mellitus, because it's over years and years of having this sort of lifestyle that leads to having diabetes. And so we see that in the clinical diagnostics, right, we would have a normal or elevated insulin because basically your body is not responding to insulin. So the pancreas goes, you still have those high glucose levels. Insulin is secreted, right, because the glucose is coming into those beta cells. And that's the trigger. So if you still have a lot of glucose in your bloodstream, your beta cells are going to continuously put out insulin. So you might even have elevated levels of insulin. But since your body's not responding to it, you're going to have still elevated blood glucose levels. You're going to have impaired glucose tolerance. And this guy I skipped over, elevated hemoglobin, A1C. This is in both. This is where you have high levels of glucose in your bloodstream, and the glucose actually attaches to your hemoglobin molecules inside your red blood cells. So we'll talk about that a little bit later. All right, so complications for both forms are the same. You will have high blood sugar for both forms. This is going to increase glycosylation of proteins. So this glycosylation of proteins, this is what I was talking about. Hemoglobin being a protein in your red blood cells, having this extra sugar in the environment, the glucose just attaches onto this protein in a non-enzymatic way. And we'll talk about that a little bit more in a bit. And then ketoacidosis is present in both forms of diabetes, but it's more common in type 1 diabetes than it is in type 2 diabetes. And we can see that management for both kinds of diabetes is similar, except in type 1, because you're completely missing the production of insulin, you have to take insulin. So insulin is mandatory in all cases. However, in type 2 diabetes, since the person is creating insulin or may have elevated insulin, insulin is used occasionally, but not all the time. Okay, so management, you must use insulin in type 1 diabetes. All right, so let's take a look at some factors, acute effects of diabetes mellitus. So when you say acute, that means it's very short acting. It lasts a very short a time, like a sudden attack of these symptoms, but it's severe. So you'll notice these symptoms, they grab your attention. So for acute hyperglycemia is basically dry mouth, thirst, and increased urination, and more severe symptoms of hyperglycemia would be hypotension, headaches, fatigue, blurred vision, and difficulty thinking. In the acute realm, there's diabetic ketoacidosis. So this is the flow chart we see here, and this is a common side effect of diabetes type 1. So remember we said that ketoacidosis is common here. All right. So in your plasma, if you have diabetes, you're going to have low insulin, okay? And then what that's going to do is for most of your cells, they're going to reduce that glucose uptake, right? So if you don't have insulin, and remember this is think about this as in terms of type 1. Low insulin, we don't have glucose uptake, and so that leads to high glucose in the bloodstream, right, the plasma. Now, if your cells are not taking in glucose, they are starving. They think that your body is not eating food, right? It's basically the same to your cells if they're not able to take in the glucose. It's the same as you just not eating any carbs. So your cells, your body is going to respond as if it's starving. And it will pump out hormones that are going to be secreted in those fasting periods. And those hormones are going to be glucagon, right? So remember that was the hormone that made you feel hungry. It's going to stimulate lipolysis, breaking down of fat, and also gluconeogenesis, just creating more glucose in the liver. That fasted state will stimulate cortisol release, which also stimulates lipolysis. And then growth hormone is secreted in times of fasting. And then that is also going to promote lipolysis. So if you take a look at our box here, where we have an increase of all of those hormones, those hormones lead to, right? So we're going to have, okay, let's talk about one more hormone before we move on here. So let's look at glucose. Let's look at our sympathetic activity. When you have high glucose in the bloodstream, it is going to act on the kidneys, and the extra sugar is going to disrupt the osmotic balance in the kidneys. And when the kidneys are filtering, you know that the glomerular filtration rate, when things are getting filtered, there's going to be more sugar that's going to be filtered out. Remember that we can reach threshold when we try to reabsorb the glucose in the PCT. We're going to reach threshold, and we're the maximum threshold, and we're not going to be able to reabsorb all that glucose. So it's going to be in the filtrate. It's going to act as a solute and disrupt osmosis, the osmotic pressure. So that is going to promote more water being lost in the urine. So more water is going to be moving into the filtrate. So it's going to promote water loss. And that, when you reduce the water, right, that means your blood volume goes down. If your blood volume goes down, your blood pressure goes down. And when your blood pressure falls, your body tries to compensate, right? So low MAP, low blood pressure. Your body compensates with that baroreceptor reflex. It's going to stimulate the sympathetic nervous system, and that's going to secrete epinephrine. Okay, so that's our fourth hormone. So we have our starving hormones, glucagon, cortisol, growth hormone. Then we have our drop in blood volume hormone, epinephrine. All four of those hormones, are listed here. They're going to get elevated in the blood, and they all lead to lipolysis. They're all going to help break down fat. When your adipose and your liver starts to break down fat, it liberates those fatty acids. Liberates the fatty acids into the plasma. So you're going to get an increase of fats in the blood so that your cells can use this secondary form of energy. So here comes the fatty acids. They're going to enter your cells. The cells will take up those fatty acids, and the metabolic process that breaks down fatty acids to make ATP is called beta oxidation. Okay, so we have more beta oxidation and elevation in that process. that creates these intermediates, all right, acetyl coenzyme A. Now that is going to travel, you're going to have a buildup of this, right? So you're going to have a lot of acetyl coenzyme A that's going to go to your liver, get converted to ketones. And that's going to cause a rise in ketones, and that's going to cause ketoacidosis. Okay, so we don't need to worry about those things. Of course, your cells are using fats to make ATP. But this is all the factors that drive ketoacidosis. So you have the hormones, you have the osmotic gradient disruption and epinephrine trying to counteract that. All of those hormones producing lipolysis, right? And all of those free fatty acids are getting catabolized by your cells. You know, they're going to pump out acetyl coenzyme A. Your liver's going to try and clear that acetyl coenzyme A by making ketones. And so that's going to flood your plasma with ketones or keto acids, and it's going to result in that ketoacidosis. Okay. And on top of that, by the way, your ketones can also be lost in your urine, and that is going to also act as a solute to draw out even more water. Okay, so it's kind of a double whammy. You have glucose that's acting as an osmotic gradient solute, and you have ketones. Okay, so I think we covered the slide here under Roman numeral 2. And as treatment, right, how can we stop this process? Is to give someone insulin, because you want to get those cells to take up glucose, use glucose, so that we don't think we're starving, right? And if we don't have elevated glucose levels, then we're not going to have excess water loss, right? And so we can normalize things. So we really want to treat that with insulin. The other thing you can do, let me just erase these marks real quick. The other thing you can do, of course, is when you are losing water, right? You want to replace that water with fluids and electrolytes. And then because we have ketoacidosis, so here's our treatment, right? 1, give them insulin. 2, water and electrolytes. And then 3rd, if it's very severe, we can use bicarbonate, because someone's in acidosis. We can use a buffer to absorb those extra hydrogen ions. All right. Ketoacidosis is dangerous. It can cause cardiovascular failure, it can cause coma, and it can cause death. So it's a very serious condition. A third, hyperosmolar non-ketotic coma. That's a mouthful. So you want to associate this with older people, elderly people. And what happens with them is that they can get these really elevated glucose levels, 600 to 2400 milligrams per deciliter. The normal range, by the way, is around 140 or less than 140. So that's really, really elevated. And glucose in this way, so we're not talking about ketone bodies or ketoacidosis. It's non-ketotic coma. So what happens here is basically that hyperosmolar. So we're creating a hyperosmolar blood. We're pulling out the water to urine, right? So the person is going to be urinating a lot. They're going to be urinating very dilute urine, and they're going to become dehydrated. And since they're losing water, their blood is going to become more and more hyperosmotic, right? More solutes going to concentrate that blood. And so remember, our normal homeostatic osmolarity of our tissues and blood should be 300 milliosmoles, but they can rise up to 325, and that's when they can hit a coma. So with this, the primary danger is not the ketoacidosis, but it's with blood clots, because as their blood gets thicker, they have more of a chance of creating these abnormal clots. And so that's sort of the primary danger in this hyperosmolar non-ketotic coma. And again, treatment's going to be similar to the last treatment. We want to give these people insulin, and we want to replace the fluids and electrolytes so that they can start to thin out the blood. So the book goes on to say that, the ketone bodies here are not a primary threat because the older population are going to have less of a response to that. Like the hormone response is going to be lesser in older people. So they're not going to have that steep rise in lipolysis, and they're not going to have that steep rise in ketone bodies from the result of like all that lipolysis. So primary concern for these guys is thick blood and blood clots. Hypoglycemic coma. So now we have an interesting opposite, hypoglycemic, below, right? A low blood sugar coma. So this would occur if a person is using too much insulin, so caused by an insulin overdose. So you put too much insulin into your bloodstream, it's going to cause a massive drop in blood sugar. Remember, you have to have a homeostatic blood sugar level in your blood. So it's less than 50 milligrams per deciliter. Let me just show you the normal range since we're talking about this, right? So this is our milligrams per deciliter. So low would be 50. Normal is somewhere between 80 and 115. So remember, we're talking about the people, that hyperosmolar. That blood sugar was between 600 and 2400. That's off the chart here. That's not even on the chart. So that's really high. So if you're below 50, that's very low blood sugar. And that can result in seizures and coma. Remember how, this is neurological, right? Seizures. Remember how the brain, the central nervous system, is always going to have a high affinity for glucose no matter what. So remember, let me actually show you that picture. Just to remind you that glucose intake into your cells, some cells are going to be dependent on insulin presence, and that was at GLUT4, right? The GLUT4 transporter. These have to have insulin present in order to take in that glucose. But then other cells, remember, like the brain, neurons, they have a really high affinity for glucose, and they don't care if insulin's around. So it's insulin independent. They will take up glucose even at low levels. So if that drops even below homeostatic levels, then the brain is going to feel it, right? Because the brain is going to be the primary organ that gets the glucose, priority over all your other neurons and brain, priority over all your other tissues. So this is a sign that your brain's not getting enough glucose. And to treat this, right, is to take in some sugar, because you want to balance out that extra insulin load that you put in and then give your body some sugar. So drinking some juice, drinking some soda, eating some candy, just getting some sugar in. And this is just showing you the blood sugar monitor. And you can always, this is why diabetics always have to check their blood sugar levels several times a day. And I'm not really 100% sure on this thing. It's like around their meal to make sure they're not going to go too high or too low. So diabetics have to monitor their blood glucose levels all the time. All right, so let's pause there and we'll start